This is the title of today. It's Root-End Operation Endoscope System. And I'm Dr. Su. I'm from the Cultural Medical University. This is my portfolio. I have a master degree in Cultural Medical University, and I'm the endodontic specialist. And thank you. I'm the endodontic specialist and the specialist of operative dentistry in Taiwan. And I am also a YouTuber. I have my own YouTube channel. You can scan the QR code to reach my channel. And I also have Facebook, Instagram, and Twitter, the social media account. So this is today's guideline. I'm divided into 4 parts. The first part is what is the Root-End Operation Endoscope System. And the second part is what role does it play in endodontic surgery. And the third part is the clinical case of my own case. And the fourth part is the demonstration and the hands-on. And let's begin with the first part. What is the Root-End Operation Endoscope System? And today we sponsored by this we call Medivision Tech. In Chinese is 医视科技. This company, they with Dr. Tai, they invent this HEROS endoscope. It's called it's the short in hemostatic endoscope root-end operation solution, and in combination with endoscope and the one capsule for apical surgery. And this is the whole picture of this system. It with a capsule made with some kind of plastic, and you can put it. It has a framework to keep this endoscope within this capsule, and you can doing the apical surgery with the for the apical for this apical surgery, and the diameter of this capsule is 6 millimeter, 6 millimeter. And there is a window within this capsule to see the apical area through the through the endoscope, and we can directly see the video right here. You put this capsule at the bone window of your apical surgery, and it can press the surrounding bone to reach the hemostasis, and you can cut the capsule to easy approach of apical area. And later we will show how to cut this. You can cut the notch for the capsule, and the apical surgery will be easier. And then this is the framework. You can put an endoscope right here, and you can see through the endoscope to directly reach the apical area. And this is the endoscope image. You can use the ultrasonic tip and the MTA feeling to for the apical area. And this is a whole picture of this system to how to use. And in additionally, the Dr. Tai, who is the inventor of this system, he mentioned that you can use the dynamic navigation system to reach the apical area, and use the tree fiber to open the bone window. And later, the Dr. Tai claimed that he used the dense arbor. Dense arbor is for the osteocondensation to expand the bone window and reach to accomplish some part of the hemostasis effect. But the Dr. Tai called this the osteo guide. But personally, I think it's reasonable. It's reasonable. It's reasonable. But I'm not very convinced with this technique. And another and additionally, they invent a new part of this capsule. They have a micro mirror direct attached to this capsule, so you can direct see. If you only use the endoscope and without this mirror, you will it will because light transfer in strength. So if you use this direct view, you can only see the part of the apical area, and this the dark triangle here is the area you cannot see. It's a it's a dead spot. You cannot see through this endoscope. So they invent a new part of this. They put a mirror here, so the apical area you can see the red line will reflect through this mirror, and you can see the image here. So you don't have this black triangle. You can also see in this mirror. So this is the capsule with the mirror, but today we don't have this one. But you can see this is the Dr. Tsai provide this image. You can see this is the true apical area, and this one is a mirror. So you can both see from here and here. Therefore, there will be no dead spot. You cannot reach. You can see also you can see the whole apical area when you do the retrograde preparation or retrograde filling. And this is the first part. We talk about what's this Root-End Operation Endodontic System and Endoscope System. And the second part is what role does it play in endodontic surgery? Because we know that the keynote speaker today, he's still giving a speech upstairs, the Dr. Kim. So many of our endodontic microsurgery concept is come from he. So he published 2006 the modern endodontic surgery. And the modern endodontic surgery combining with microscope and ultrasonic tip and the micro mirror, and all this combination, we can do the modern endodontic surgery. It's different from the old school apicoectomy because the old school use the high speed. And if you cut the apical area with the burr, and it might have some, it will have a more bevel, or you cannot cut all through the apical area. And if you use the ultrasonic, when you do the root-end preparation, you can preparation a very fine and very small apical foramen, and you can see through the micro mirror, and it will be very clean. So this is the concept of the modern endodontic surgery. And also in Dr. King's paper, he mentioned about the microsurgery successful rate is 88 to 100%, and the traditional one is 43 to 74%. So the difference between the microsurgical technique and the traditional technique is there no bevel less than or the bevel is less than 10 degree in microsurgical, and expose few dentinal tubule, and they have a small osteotomy and minimal loss of buccal plate, and no danger of perio communication, and easy identification of apex. and no lingual perforation. And otherwise, I don't read the traditional technique because I think today we all use the micro surgery and include like the previous slide says the 4 mm bone window will be enough, and we will use the ultrasonic tip to do the retrograde preparation. And if you use the high speed to cut the apical to do the retrograde preparation, you will be acute angle. But if you use the ultrasonic and the modern technique, it's a shallow angle, and we cut the apical part of 3 millimeter to remove the most of the apical ramification and the lateral canal. And another we use the MTA or bioceramic to fill the root end, and it appears that the bone will grow in, and the tissue condition is good. So this is the modern endodontic surgery. And this you if you use the micro mirror and the microscope, you can see all this like the dead space after the root canal filling, or the isthmus of the two canal connection, or the fracture line. You can see all this is very clear in microscope. And Dr. King also published this book in 2017. The whole concept is the same with the 2006 paper, but they upgrade the microscope and the microblade, like 15C or micro perio blade. And he also invent a lot of the apical preparation tip, or the apical filling part instrumentation, or other curated or some kind of the new instrument. But the concept is the same. And in previous paper, he mentioned that 4 mm bone window is enough. And if you open only 3 mm, you can do a notch, a little notch at the opposite of the apical area. Then you can put your ultrasonic tip here, and you may have a less the smaller apical bone window. This is a modification of his concept. And also, he introduced the piezo tone technique to remove if the buccal bone is intact, you can remove the buccal plate, like a rectangular plate, and you remove it. You put it in the HBSS solution, and after you do all the retrograde preparation and the retrograde filling, you can put some bone graft or something, or collagen fiber, collagen material, and put the bone plate back inside, and maybe you put some membrane to cover it. And this is one of the new concept he introduced in his new book. But the cutting the 3 mm of the root, and the cutting 90-degree angle is the same. Is all the same in the back old paper. And also he introduced some, maybe you put some pillow, and to modify the patient position with some pillow that you can have a better position of microscope and your own ergo position. And he also introduced that you can a little bit bevel or less, nearly no bevel, and you can still use a microscope to direct see the apical area. But like this, you still have the dead spot that you cannot see. So use the microscope, use the micro mirror is the best to see whole the apical area. And so if the microsurgery, the concept is very intact, very perfect. So what's the purpose of the endoscope and the capsule? And this is my opinion, of the consideration during the usage. We can use the endoscope when you don't own your own microscope, like some hospital or some local dental clinic. You don't have one. You don't have the microscope. And another one, if you have a bad surgical field view, like the posterior tooth is very hard to maintain the surgical field view, or the patient has thick cheek, and or the bone cavity is very deep, like in posterior lower tooth, the bone cavity is very deep, and you are unable to reach it with the micro mirror. And it's the one of the concept that is, I think it's not necessarily required to use with the capsule. You can combine it together, but you can use the endoscope singly. And another one, you can use the endoscope to beyond the apical surgery, like Simon's lift or perio surgery, or some another way. And in the capsule, personally, I think you don't have to use these two together. You can use the capsule with an endoscope, and you can also use the capsule with the microscope, and you can use the capsule after you do the static or dynamic navigation. And the capsule can do is what it can do is hemostatic, and to moisture control in Root-End surgery, because it's plastic, and it can keep the blood outside, and it can prevent the contamination of the bone cavity when you do the Root-End preparation. The GP or the bacterial contamination will spread all the way. And if you have this plastic capsule within your bone cavity, it will not. If you have done some of the apical surgery, you remove when you removing the gutta percha, you can see the gutta percha, a lot of particle sink into the bone cavity, and it's not easy to clean. So this one is the significance, one of the significance that I think the Xis capsule can do. And so I would like to call it the apical rubber dam. And I remind you, if you use the capsule, always trim it. Because the bone cavity will not be fit if you don't follow the Dr. Tsai's concept. It will a little bigger or something. We will demonstrate in the hands-on. And the dynamic and the static navigation is another topic. So if you are interested in this, you can scan the QR code to reach my previous video. Okay, so let's see some clinical case. This one is the capsule with endoscope, and this performed in Kaohsiung, and where I don't have a microscope. So this one I do the apical surgery with capsule and then and with endoscope. So you can see the apical lesion in the tooth, the right upper central incisor, and the back filling quality, and maybe with some apical the root resorption at the apical area. And this is the endoscope image. You can see the gutta percha is maybe contaminated and is not well filled. And I use the ultrasonic tip to remove it. And the endoscope, the camera is waterproof, so you can always spray some water, and if it have some if it is not clean, if you see it's not clear, you can just use the water to spread on it. And after I remove the gutta percha, you can see the metal post, and this is the fracture line within. But patient after the discussion with patient, we still do the apical field, retrograde field with MTA first. And this is the apical area that I cut off. You can see maybe has some intraradicular infection, like maybe calculus or some contamination on it. And this is the image that I using the endoscope with a capsule. And this is a post-operative operation. And we cut the root and we fill with MTA. And the second one is also performed at the Kaohsiung Chiching Hospital, where there is no microscope. So this one, he has gumboiled over the left lower second molar, and I decided to do because the feeling quality is bad, so I decided to do the endodontic retreatment first. So after I remove the post, and I remove the gutta percha, and I do the clean and shaping, and after I feel the tooth, patients still have sinus tract. So I perform the endoscope surgery. This is the because there is no microscope, so this is the direct use the camera to take the photo. And after I reflect the flap, and I open the bone window, and after I cut the root canal, cut the root, and I put the capsule with microscope inside. Then this is the after the retrograde filling, and this is after suture. And this is the image of the apical surgery. So this is the gutta percha, and you can see maybe there's a lot of blood spot of the apical area, maybe contamination. And as you can see, the blood will flush, but if you put the suction outside, it will the blood and the water will suck out with the capsule. And always know that always you can take the endoscope out of the capsule, and you also can use the micro mirror with the endoscope. When you don't have the micros, you can use the endoscope with micro mirror. Yeah, you always can take it off and to do this with microscope endoscope alone. And this is I use the MTA to do the retrograde filling. And this is after the retrograde filling. You can use the endoscope to check, and with the micro mirror, and at all the view. Okay, so this is the post-operative. And this one is the case 3. This one I use the capsule only with microscope without endoscope. And I do the surgical guide is static navigation. We can see that okay. This one is the periapical view, and we can see that the mesial root is with the periapical lesion. But after I check the CBCT, we will find out that the distal root is also got an apical lesion. We see this CBCT again. This one root, this one. And here is the mesial root. This is the distal root, and both with apical lesion. And this one we suspect it is a vertical root fracture. So after this, we still design the surgical guide to do the guide surgery. So I use the 3D printer to print the apical this guide plate to do the apical surgery with tree fiber. And I use the 5mm tree fiber. If you still remember that the capsule is 6mm, and I opened with the 5mm tree fiber, so the capsule will be too big. So we have to trim it. And the mesial root is the lesion is very big, and I think it's easy to conduct microsurgery. So I didn't put a capsule. And this because we suspect it has a root fracture, but after we remove the granulation tissue, we found this one is the mesial lingual canal. This one is the mesial buccal canal, and with the isthmus there. And at the buccal side, we have mesial buccal transportation at the middle of the root of the apex. So I remove all the gutta percha and connect these three holes together to make a long cavity and fill with MTA. This is the mesial root. And the distal root is because the mesial root we got the penetration here. It's easy to locate the lesion. So, but the distal canal, the distal root, we don't have the penetration. So we use the guide to do the use the tree fiber to do the osteotomy, and we remove the bone plate. And this bone plate, I didn't put it in the HBSS, but I put it in the normal saline. And we remove after we remove the root section, root segment with the trim fiber, and we trim the capsule, and you can see we trim the capsule very short and more small. And we use the endoscope. We don't use the endoscope. We use the micro mirror and the microscope. Within this capsule, we do the retrograde preparation. And you can contain the contamination in this area, and the blood control will be easy too. And this is the MTO retrograde filling. And we pull out the capsule. This is the after retrograde filling. And we put a collagen inside, and we put the bone plate back, like the piezo technique. We put the bone plate back where it come from. and we did the suture. Okay, and this is the root segment that I remove. This is the mesiobuccal root. This mesiobuccal canal, the mesiolingual canal, and the distal canal. And I have to remind you, if you want to use the capsule, you always trim it, because the capsule is 6 millimeter in diameter, and my bone cavity in this case is 5 millimeter diameter. So I cut this part I cut off this part, and it will be more small, can fit in my bone cavity. And this is the post-operative. And so this is the lecture today, and maybe we do the demonstration and the hand-on. If you have some question, you can ask now. 好像没有外国人哦，我可以讲中文。是，请问，剪刀，我们等下会示范。当然你想用 low speed 车也是可以。剪刀就剪得动了。它那个我记得那个蔡司是说那个材料是就是应该是有通过认证的，是可以接触到手术区域的。不确定是哪一种塑胶，我没有问他。你怎么确定你吹完之后放进去会刚好符合那个 size？ 它其实有弹性所以这个跟你在修 temp 一样，就是不要修太多，一次不要修太多。就是它这边有一个，它这边有一个沟槽嘛，所以它其实比 cavity 大一点点还是塞得进去。你如果一下吹太多就会很松，你就要吹第二个。所以你如果问我剪个1-2次就会了，大家可以试试看。对所以我自己是觉得可以把2个拆开来用了。它是出一起的，但是我觉得就如果你没有显微镜，你可以2个一起用。如果你有显微镜的话，你可以单用这个就好了。有一些那个内视镜可以用的其他的功能不过这个我们主要是讲这个 endo surgery。对啦，但这个几个就是如果我曾经念过 Dr. King 的书，其实照他的 protocol 做止血效果就很好。Dr. King 他就是拿掉之后，就是看你是要用那个硫化铁还是什么，或者是用 epinephrine 就是棉球直接塞进去，塞一段时间，其实它就止血功能很好。那它 capsule 塞，就你如果有做那个止血再塞 capsule， 其实止血会很好你直接塞 capsule 的好处，一个是你就是你把 suction tube 直接放在那个，就是它这边有一个沟槽，然后你把 suction tube 放在外面，它就会跟着，就是因为血液接触到它在 bone cavity 里面嘛，那它从 bone 的 cavity 渗出来的时候，它会先碰到外壳嘛，那碰到外壳之后，它会有一点那叫毛细现象嘛，它就是会粘在 bone cavity 跟这个外壳的中间然后你把 suction tube 放在这里的时候，它就是会一直被吸出来，所以你只要放在那边，它就会一直被吸出来，比较不容易影响到了。不过它有一个缺点是，它就是有这个 window 有时候你那个 spatula 在放的时候会卡到，所以这个一方面我觉得是要练习另外一个点就是提出来，就是你在清 cavity， 你在清那个 GP 的时候，它比较不会粘在那个叫什么那个海绵骨的小洞洞上面，